Dr. Shifa.
Financial disclosure. Multiple myeloma is a hematological malignancy which is characterized by the accumulation of clonal and malignant plasma cells in the bone marrow. It produces abnormal immunoglobulins such as M protein and paraprotein. Therefore, it is known as paraproteinemia. It is detected in the blood or in the urine of multiple myeloma patients. It is a treatable but not curable disease. Clinical features are bone pain, fatigue, weakness, frequent infections, anemia, renal failure, hypercalcemia. Ocular findings are corneal deposits, scleritis, pars plana cyst, choroidal infiltrates, retinal capillary microaneurysm, hyperviscosity, retinopathy, maculopathy, and CRVO. So I present a case of 62-year-old diabetic female which came with a decrease of vision in both eyes since 1 year. She was diagnosed elsewhere as non-proliferative diabetic retinopathy with macular edema in both eyes, and she was treated with intravitreal anti-VEGF injection in both eyes and triamcinolone in the right eye. Followed by there was no improvement in treatment, so she came for a second opinion. On ocular examination, her best corrected vision was 6/24 N18 in the right eye and 4/60 N36 in the left eye. Her anterior segment findings were normal except there was early cataract changes. On fundus examination, there was a large neurosensory retinal detachment with yellow subretinal fluid exudates. On OCT, there was a huge neurosensory detachment in outer retinoschisis. On FFA, we reviewed her old FFA. There was no perifoveal leak corresponding to the degree of neurosensory detachment describing as silent macula. So angiographically silent macula rules out that the disruption of the blood-retinal barrier is the primary mechanism for the subretinal fluid accumulation, thus ruling out to be diabetic macular edema. It prompted to look for other systemic conditions like compromised renal function. So we did a renal function test and it came to be out normal. So refractory nature of the macular edema, normal renal function test, and silent macula on the FFA prompted us to evaluate for immunoglobulopathy. We investigated electrophoresis which showed M proteins. We did a whole body PET scan and bone marrow aspiration which suggested of a multiple myeloma. Then we started a medical oncology consultation and chemotherapy was started. On follow-up, there was no improvement in vision, but fundus show resolved neurosensory detachment and signs of NPDR with RPE changes. On OCT finding, on both eyes, there was complete resolution of the neurosensory retinal detachment and subfoveal RPE changes was present in both the eyes. On FFA, there was a window defect in the macular area and NPDR changes were seen. So our final diagnosis was both eye paraproteinemia maculopathy secondary to multiple myeloma with early cataract and mild NPDR. Discussion. Paraproteinemia maculopathy is a rare ocular manifestation of monoclonal gammopathy like multiple myeloma. There is an increase in the level of IgM which enters into the subretinal space causing local ischemia and increase in the osmotic gradient causing accumulation of fluid in the subretinal and intraretinal spaces causing neurosensory detachment, thus showing in FFA as angiographically silent macula and excluding the blood breakdown of blood-retinal barrier. So the silent macula is a crucial feature distinguishing from the macular edema due to breakdown of blood-retinal barrier seen in the diabetic macular edema, age-related macular degeneration, uveitis, and retinal vein occlusion. We also need to rule out other ocular and systemic conditions such as retinal dystrophies, optic nerve head pits, myopic tractional maculopathy, toxic effects of drugs such as taxanes and Cohen syndrome. This can be excluded by history and examination. So my take-home message is, though rare, paraproteinemia should be suspected in middle-aged to elderly patient with macular edema. In case of silent macula on FFA, early recognition and referral to an oncologist leads to timely diagnosis and appropriate management, save life and save sight. Thank you.
Postgraduate?
Yes, sir, I'm second year.
Okay. How do you classify macular edema on a fluorescent angiogram? Diabetic macular edema.
Sir, there's on FFA, sir.
Yes.
There's leakage of the microaneurysm leakage, hyperfluorescence.
How do you classify?
Classify, sir.
Is there a classification, FA-based classification of diabetic macular edema, clinically, OCT-based and angiogram-based?
OCT-based, we have a classification.
Angiogram-based, is it is there?
Angiography.
I've heard of ETDRS study.
Yes, sir. Early treatment and diabetes.
So it does give FA classification. Are you aware of that? Yes or no? So you are presenting a case on
Yes.
this, so you should be aware of it,
Yes,
right?
sir.
So basically, silent macula, by saying silent macula, what we mean is any
There's no
diabetic
leak-
patient, when
yes.
you come across macular edema and you're not able to find the cause for it. So what is the
Yes.
cause for diabetic macular edema? Either a leaking
Leakage.
microorganism
Yes, sir.
or a leaking capillary,
Hmm.
right? On an FA,
FA.
you are neither seeing a
Neither
leaking
any
microorganism
leakage.
nor a capillary.
Yes.
That means the source of leakage is from.
Somewhere else.
So now
Translation.
diabetes is
Yes.
not the cause.
The
So
cause
this
of
is
the-
how you end up, though the
Yes.
patient, the diagnosis leads towards the diabetic macular edema.
Yes.
These are the red flags
Red flags.
where you have to see that, okay, this is not because of diabetes and because of something else.
Something else.
And then you go on investigate.
Yes, sir.
Okay, right.